Sir.
Good evening, everyone. It's my pleasure to welcome you all for today's virtual scientific meeting. We are privileged to have with us two esteemed medical oncologists from Coimbatore Government Medical College, Dr. K.B. Akila ma'am and Dr. Nitya Priya ma'am. They will be sharing their insights on the landmark of ARASENS and ARANOTE studies, focusing on the evolving treatment landscape in metastatic hormone-sensitive prostate cancer. Thank you, both the doctor, for joining and sharing your expertise. Over to you, doctor.
Good evening, all of y'all. I'm Dr. Akila, medical oncologist at Coimbatore Medical College Hospital. But before I start, I thank Bayer for giving me this opportunity. And my talk today is on metastatic hormone sensitive prostate cancer. All of us know we have androgen deprivation therapy. Prostate is going to be a hormone dependent malignancy. So all what we have to do first is lock off the hormones, all the secretions of the hormones, and then go ahead with what is possible. So all of us know androgen deprivation is the key management in prostatic malignancy. Beyond that, what all do we have? We all have a lot of options now. Next slide. 1 minute. Next slide. Yeah. So yeah, I think here we have once we diagnose a patient with locally advanced or localized prostate malignancy, then we treat them. What happens to those patients? They come back to us with biochemical recurrence. So what happens when they come back to us with biochemical recurrence? We will definitely put them on androgen deprivation therapy. From androgen deprivation therapy, they can go ahead into hormone sensitive or resistant prostate cancer. So they can either become sensitive or resistant. But once they become resistant, that's the end of prostatic cancer patients. All patients who suffer and die of prostatic malignancy have these castration resistance or hormone resistant treat to therapies. So, and the improvement in the overall survival is only around 2.5 to 4.5 months. So this is the same. So we now concentrate mainly on hormone-sensitive prostatic malignancies. So what can we do? All what we have to do for these patients is keep them hormone-sensitive so that we can delay their resistance to hormones and thereby improving their final outcome. So our main goal in treating a metastatic prostatic cancer patient is keeping them hormone sensitive as long as possible so that their final end is delayed. So Stampede trial, all of us know that's the first, coming to chemotherapy era, it is docetaxel, which is, I think, the chemotherapy which has been proven in prostatic malignancy. Then came the Stampede trial. In Stampede trial, there was, when we see the overall survival, it was significantly there for 5 months compared to the event-free freedom from survival, which was only around a year. So what happened after that is we can do much better after Stampede. So what are we going to do? So Stampede also compared the addition of radiotherapy to the standard of care. So what happened? Again, we have to divide the prostatic malignancy into the volume according to the volume of disease. So it can the high risk, high volume and low volume. So low volume is when the bone mass is less and high volume is when the bone mass is more. So when the bone mass is more, definitely the prognosis, the overall survival is less compared to when the bone mass is going to be less than 4. So this is the slide showing that. So that is by adding radiotherapy, definitely we are going to improve. Then came how we are going to improve further outcomes with systemic chemotherapy. So all of us know there are many trials, Stampede, Charted, again Stampede 4, Latitude, Archie's, Titan. See here all became like adding of further hormonal deprivations to chemotherapy arm. So that was the era of abiraterone, enzalutamide, apalutamide. And now we have further androgen deprivations, which is going to be darolutamide. So how is all this going to be useful for us? So these androgen deprivations have been slowly, the innovations have been progressing from 2013, and now we have the best agent with us, which is darolutamide, in managing these hormone sensitive patients. So what had happened if we use only docetaxel plus androgen deprivation therapy in a high volume disease versus androgen deprivation alone, the survival increased from 34% to 34 months to 51 months in a high volume disease by adding dosi to androgen deprivation therapy. Same if it is a low volume disease, dosi alone gave an increase in survival to almost 5 years with a significant p-values here. So then came Latitude. What did Latitude do? Latitude added abiraterone in high risk. 1 minute. Sorry. Yeah. What did Latitude trial do? It was like adding abiraterone to the standard of care in high-risk metastatic prostatic hormone-sensitive prostatic malignancies. So what did they add? They had the androgen deprivation therapy plus abiraterone acetate versus placebo. What happened? Definitely there was a survival improvement from 36.5 months without abiraterone to almost 53.3 months with abiraterone. So this was the first, this is another trial which showed that hormonal treatment is effective. However, we have to know that the treatment journey is the most important in the control arm. So we have to clearly monitor the PSA for these patients. So how long we are going to delay in the biochemical recurrence is the most important thing in prostatic malignancy. So considerations for abiraterone, what do we have really? So we usually add also 5 milligram of prednisolone. So what happens when steroids are added? Definitely there is hypertension, hepatotoxicity, liver enzymes can be there, grade 3 hypokalemia can be there, and fluid retention and the side effects of steroids, which is going to be osteoporosis and cataract are definitely going to be there. So that is the most important thing in these patients. Then after abiraterone, what did we have? We had this enzalutamide and apalutamide. So Titan was a trial where apalutamide was used along with androgen deprivation therapy versus placebo with androgen deprivation therapy. What happened there? Definitely there was an increase in the progression-free survival. If we see the hazard ratio, it is 0.548, which means at least 52 out of 100 patients had a significant improvement in PFS with apalutamide. The same if we see in low volume disease versus high volume disease, definitely the hazard ratio was 0.53 even in high volume disease, which means even in high volume disease, 50% had a benefit with by adding apalutamide. So then came the enzalutamide, the same here, hazard ratio was like 0.4, which means like 60% of patients benefited with enzalutamide, and the overall survival was 0.67, which means almost like 30% of patients had an improvement in the survival by adding enzalutamide to androgen deprivation. Hereby, what do we really mean? Androgen deprivation is the testis is being knocked off or the patient is put on like LHRH analogs. So how do we further improve the outcome for these hormone-sensitive prostatic malignancies? Then here came the PEACE study design. What is this? What did this do? See, the inclusion criteria in this was hormone-sensitive prostatic malignancy patients who are de novo metastatic. These patients were de novo metastatic, less than 3 months of androgen deprivation prior to randomization, no prior systemic chemotherapy. The patients were ECOG performance 1 or 2. Patient could have mets either in the bone or visceral mets were also taken. Of course, androgen deprivation is like either LHRH agonists or orchidectomy, and also LHRH antagonists. Docetaxel, yes or no, but of course 3 months. So this is here. The patients again were randomized to standard of care plus radiotherapy versus standard of care plus abiraterone plus prednisolone. See, radiotherapy was added to the arms. That is either standard of care plus radiotherapy alone or standard of care plus abiraterone plus prednisolone and radiotherapy. So this was a randomization which happened in the PEACE 1 trial. So here, what did we see? Definitely, if the patient has high volume disease, what had happened? In high volume disease, the events had definitely increased. I mean, the median survival had increased from 3.5 to 5.1 month in patients with when we added abiraterone. The same if we see in a low volume disease, the events improved from 31 to 29. So it is better, like if the patient, the benefit was more in high volume disease. So that is what we have to know here, that even in high volume disease, we can improve the outcome by adding abiraterone to docetaxel versus docetaxel alone. Then came a newer molecule, darolutamide. What happened here? Again, a trial was done to prove the efficacy and the benefit, the prognosis significance, and also the toxicities of darolutamide. And the study which was undergoing this is a RASIN study. This was a global, randomized, double-blinded, placebo-controlled study. So what had happened? It was again the hormone-sensitive prostate cancer patients with ECOG performance less than 1, candidates for androgen deprivation therapy and docetaxel. Stratification again, extent of disease, they saw whether it was M1A versus M1B versus M1C, and also the liver enzymes were taken into considerations. The randomization had begun long way back in 2016, and the data cutoff was 2021. The patients were randomized to docetaxel 6 cycles plus darolutamide versus dosi and placebo. The endpoint of this study was overall survival, which was the primary endpoint. The secondary endpoint, all of us know that delaying the hormone sensitivity or making time to castration resistance is the most important secondary point. Time to pain progression, symptomatic skeletal event-free survival, time to first symptomatic skeletal event, time to initiation of subsequent antineoplastic therapy, time to worsening of physical symptoms. See, most important is like we are going to delay the biochemical progression and also the symptoms. See, all of us know bone mets is a common in prostatic malignancy, and most of the patients have severe pain. So time to pain progression is all our primary or secondary aim in treating prostatic malignancies. So once pain is there, the patient is going to start using opioids. We have to delay the initiation of opioids in these patients. So the adverse events between these arms were both almost identical. So 87% of patients received 6 cycles of dosing. And what had happened to the overall survival? Definitely there was an improvement in overall survival. 13% improvement in the overall survival at the end of, 4.5 years. So it was like the overall survival increased from 50% to 63% with a hazard ratio of 0.68, which means like at least almost 30% of patients had a significant improvement in the survival. And the median survival for these metastatic prostatic patients was almost 48.9 months. So benefits here, the most important thing is till this molecule, the main benefit was seen only in high volume disease patients. But here, when we see this molecule was beneficial even in low risk patients. So that is the most important thing we have to remember. This molecule was helpful even in low risk disease with a hazard ratio of 0.62, which means at least 40% of patients benefited with the use of darolutamide. And of course, high risk patients definitely benefited with this molecule. See, like what we have to know, definitely time to the resistance. Time to the resistance was significantly delayed. The median was almost a 20-month increase with placebo, but as it had not reached at the time of cutoff for castration resistance. And the first subsequent anti-neoplastic therapy, definitely it was significantly delayed when we used darolutamide. See, it was 25 months when we had used placebo versus it was not yet reached till, the analysis was done. And here the hazard ratio was 0.39, which means almost 60% to 61% has a risk reduction in using subsequent anti-neoplastic. So the skeletal events, definitely there was a delay in this time to first skeletal event, and time to pain progression, definitely at least 20% of patients benefited by adding darolutamide. So these were the main thing in prostatic patients is the pain. So we are trying to make them more hormone sensitive, make more pain-free. We are delaying the skeletal related events and delaying the further anti-neoplastic therapy. All this could be achieved with this molecule. So, and of course, most of us have to monitor the patients. We cannot be repeating the imaging every time. So what we really do is like PSA is going to be our standard monitoring for prostatic malignancy patients. And when we monitored, it was seen at 24 weeks, 36 weeks, and at any time. Definitely, there was a significant undetectable PSA patients. So if we see at 24 weeks, 24% of patients had undetectable PSA if we had used placebo. But the same, if we had used darolutamide in these patients, the undetectable PSA was seen almost in 50% of patients. So the same, this effect was significantly being the same even at any point of time. So by the progression in PSA was not seen, which means the biochemical regression continued to be there. And time to PSA progression, it was detectable at 36 weeks if we had used placebo, but it was undetectable even at 36 weeks if we had used darolutamide with a hazard ratio of 0.2, which means almost 80% of patients are benefiting with darolutamide. So more than 2/3 of patients reached below 0.2 in the overall study. So coming to the overall survival, again, definitely the PSA was undetectable at 36 level with a hazard ratio of almost 0.37. So this is the most important in this by using darolutamide. So this is again the same thing, placebo plus androgen deprivation plus with docetaxel. Definitely the PSA was undetectable when we used this molecule. And triplet also achieved long periods of no disease progression with a significant improvement in the overall survival. So most important is we are delaying the tumor becoming more resistant to hormones. So again, the overall survival, the median had not reached, but if we had used placebo, it was just around 22.1 months. This is again the same thing with undetectable PSA, darolutamide plus with dosi. Again, at any time, we could see that using this molecule had a beneficial with a time to PSA progression, which had not reached when we used darolutamide. But the same, if it was androgen deprivation with dosi, the PSA progression happened at 33 months with the overall survival with the median not being reached in both with a hazard ratio of around 0.3. So things to consider. Of course, all of us know now, like whether it's have to use. I think by now all of us are clear that it is going to be a triplet in hormone-sensitive prostatic malignancy. What we are going to use definitely is the most important thing. Most important is delaying the making the patient more hormone sensitive and delaying the resistance to hormonal therapy is our aim in treating prostatic malignancy patients. We have to see that the patient is pain-free because the patient has more bone meds, which is going to be painful. We have to see that the use of opioid is getting delayed. We have to see that the patient is comfortable without side effects. And the most important here is like how much are we going to delay to resistance is the most, to hormones is the most important. So here things to consider is, and also most important is whether the patient is having low volume or high volume. So what molecule should I use in case of low volume disease so that the patient is going to be more hormone sensitive? So what do we have to consider here, whether triplet or doublet? I have to see whether the patient is going to be able to tolerate and accept dosing, the extent of disease, the likelihood of hormone insensitive clones. That is how long the PSA progression has happened, age or life expectancy of the patient. Prostate cancer will be the cause of death if diagnosed early. Will docetaxel be an obligation in the near future? Patient needs to be informed of the options. So all this has to be decided, taken into consideration when we treat prostatic malignancy patients. So most important in this talk, what we should know is any prostatic malignancy patient, we have to keep metastatic disease. The aim should be to keep them hormone sensitive as long as possible. That is the most important thing. And now we have an agent where we also our aim is achieved even in low volume diseases. So I think I end my talk here and over to Bayer for.
Thank you very much, Dr. Akila ma'am, for the insightful and informative presentation. We truly appreciate your valuable perspectives on the recent study and your clinical insights. Now it's my pleasure to invite Dr. Nitya Priya ma'am. Before that, ma'am, Akila ma'am, there are a couple of questions in the chat box. Shall we handle that after this session, ma'am?
Sure. After Dr. Nitya finishes.
Yeah. Thank you, ma'am. Thank you. And now it's my pleasure to invite Dr. Nitya, ma'am, to take us through the run-out study. Over to you, ma'am.
Good evening, ma'am. Good evening, everyone. I am Dr. Nitya Priya. I will discuss about the doublet trial, Aranote. Arumutham, can you stop sharing?
Ma'am, actually, Akila ma'am, could you please stop sharing, ma'am?
1 minute.
Yeah, please, ma'am.
Stop sharing.
Yeah.
I'll read.
Is it okay now?
Just a minute.
Yes, ma'am.
Is it visible?
Yes, ma'am. Fine, ma'am. Please go ahead, ma'am.
Good evening, everyone. Advancing metastatic hormone-sensitive prostate cancer taken to newer horizons with darolutamide without chemotherapy. So it is a discussion of evidences provided by Aranaut. So it's a disclosure, and here is the timeline of evolving standard of care in metastatic hormone-sensitive prostate cancer, starting with initially ADT alone, then with ADT with the docetaxel, then with abiraterone in latitude and stampidam F, and then followed by Arcase, Enzamet giving enzalutamide, Titan giving apalutamide, and then came Arsens triplet in 2022, and now we have the Aranaut with darolutamide plus ADT in patients with who are either not eligible or refusing docetaxel. So what's the unmet therapeutic need for this study? Darolutamide in combination with ADT would provide efficacy benefit with a favorable safety profile in metastatic castration-sensitive patients, as demonstrated by this study. And the darolutamide shows a very low significant low incidence of significant toxicities. So if it can be provided along with ADT alone without docetaxel, it will be like more levering towards the favorable safety profile. So darolutamide plus ADT with docetaxel has been a standard of care, as already explained by Man very well. And now Aranaut was designed to evaluate darolutamide plus ADT versus ADT, so as to provide a new treatment option for metastatic hormone-sensitive prostate cancer without docetaxel. Basically, it is like replacing other ARPIs. So the study design, it is a randomized double-blind placebo-controlled phase 3 study. It was double-blind phase till primary analysis and then open label. So inclusion were metastatic hormone-sensitive prostate cancer, either histologically or cytologically confirmed adenocarcinoma of prostate with a good ECOG performance status up to 2. And in stratification, they were divided into either visceral mets were present or absent, marking the high risk and high volume and low volume, and prior local therapy was given or not. So there was a 2:1 randomization with one arm receiving darolutamide 600 milligram twice a day plus ADT. Then another arm received placebo following ADT. So the primary endpoint was radiographic progression-free survival, and the secondary endpoints were OS, which was the key secondary endpoint, then time to initiation of subsequent anti-neoplastic therapy, then time to castration-resistant prostate cancer, time to PSA progression, rates of undetectable PSA, stringent control of less than 0.2 nanogram per milliliter, then time to brain progression, then the safety profile as assessed by the CTCAE grading. Then other pre-specified endpoints were also included, like PFS2, time to skeletal events, second skeletal events, time to deterioration of FACT-P, which is an important measure of the quality of life in prostate cancer patients. Then time to first prostate cancer related invasive procedure. So after the primary analysis, once it became open label, the patients were allowed 100% crossover. And as we see in the demographic and clinical characteristics at baseline, almost all are comparable in both the arms, and can significantly note that there is a significant almost 30% of Asian population included, and there is a de novo population included around 70%, and there is a high disease volume, high volume patients are also included, amounting to 70% in both arms. So this picture denotes the representation, how far we have been represented in this trial, and among the APAC regional representation, India contributes nearly 13% in both the arms. So coming to the results, darolutamide plus ADT significantly reduced the risk of radiological progression or death by 46% when compared to the placebo plus ADT. As we see at 2 years, both the lines start separating as early as 3 months, but by 2 years we can see the significant difference. Like it's 52% with the placebo plus ADT plus placebo, and it is 70% with ADT plus darolutamide. So and the hazard ratio being 0.54, and it is statistically significant. And here is the forest plot, is the subgroup analysis with the all subgroups falling to the left of the line, and we can see the Asian group included, the visceral mets included, the disease, high volume disease included. So there is nothing, like everyone falls to the left of the line. As we see, the disease volume is included. Then darolutamide plus ADT demonstrated a benefit across all the secondary endpoints as well, though the median has not been achieved in these endpoints, like the OS, time to metastatic CRPC, PSA progression, time to initiation of subsequent therapy, and time to progression. So, and we have yet to receive the final results. So it delayed time to CRPC and time to progression, as we see in the curves separating as early as 3 months. Though the median has not been achieved, we can see there is a wide gap both in metastatic CRPC, time to metastatic CRPC, time to pain progression, and the PSA levels, non-detectable levels are like at any time, it's like very significant when compared to the placebo arm, and time to PSA progression is also like has a wide gap. As we see, when compared to the placebo, both in the high volume and the low volume, the darolutamide shows a significant proportion of the patients have achieved like deeper response, undetectable PSA, which is in fact a significant prognostic factor. So subsequent life-prolonging anti-cancer therapies is like we can see that it's almost similar in both the arms. And now coming to the treatment-related adverse events, we can see that it is almost similar in both the arms, and grade 3, grade 4, grade 5, all are almost similar. In fact, grade 5 or lesser in darolutamide arm. And another important point to note is that permanent discontinuation of the treatment is like significantly less with the darolutamide arm. Again, these are the most common adverse events, which are like, even if they are not very significant or very risky, they are like very bothersome to the patient, like fatigue, falls. They are also very less with the darolutamide arm. I mean, like it's actually comparable. So the rates of adverse events commonly associated with the ARPIs were like similar with both the treatment arms, especially the adverse events commonly associated with other ARPIs like hypertension, cardiac arrhythmias, rash, fatigue, then coronary artery disease. They're all like actually comparable with the placebo arm. So this actually reflects in the fact P total score, which actually is better than placebo. So we can see that in the KM plot. And when it comes to the social and family well-being, functional well-being, the symptoms, LA2S, so everything actually the darolutamide arm scores well over the placebo arm, which is in fact a very important in prostate cancer patients. So this is what it is. As we already had, madam had clearly explained like what chartered is like high risk versus low, high versus low volume, whereas latitude is high risk. Stampede is like, it gave RT to prostate as OS benefit. Then Stampede also advocated use of abiraterone both low and high volume disease. So concluding, darolutamide plus ADT significantly improved radiologic progression-free survival in patients with metastatic castration-sensitive prostate cancer. And it actually showed benefit across all secondary endpoints, though median has not been achieved yet. So also it shows a deep PSA response regardless of the baseline PSA. And regarding the functional parameters like pain progression, overall well-being, so functional well-being, urinary symptoms. Actually, they have like they are clinically. I mean they're significantly better than the placebo arm. And overall, important. Above all this, the darolutamide has a very favorable safety profile compared to the other ARPIs with similar efficacy. So this puts it on the top. So finally, the darolutamide plus ADT without docetaxel can become an additional standard of care for metastatic hormone-sensitive prostate cancer, like where docetaxel is not indicated and where docetaxel cannot be given to the patient. Darolutamide plus ADT becomes a standard of care. Thank you.
Thank you very much, Dr. Nitya ma'am, for that excellent presentation and for clearly highlighting the key findings of the ARANOTE study. We sincerely appreciate your valuable insights, ma'am. Now, the floor is now open for questions. I think there are 4 questions in the chat box. Akila ma'am, could you please unmute and a question asked to you also, ma'am, Nitya ma'am.
Yeah, 1 minute. I mean.
Yes, ma'am.
I think first question is like if a patient progresses after anti-androgen therapy with darolutamide. I think here my answer will be like docetaxel will be the first option because I mean that is less toxic than cabazitaxel, and of course PARP inhibitor if the patient has a mutation, and if lutetium and PSMA it is available also. I think that is preferred after using the taxanes for these patients. And coming to the second question, it is like how many Indian patients? No, I think most of our patients do tolerate and will be able to tolerate this molecule. And the study has clearly shown like by using it in the front is the most important. So I think definitely we have to go ahead with this molecule if there is no issue or financial constraint for patients in India. And I think prostatic malignancies, definitely the ECOG performance status is much better nowadays. And coming to the third question, it is like a 68-year-old man with high volume disease, ECOG performance, status 2, diabetes, hypertension, mild neuropathy, reluctant to receive chemotherapy. Recommend Arasen style triplet or doublet. I think I will definitely go ahead with androgen deprivation with darolutamide, because I think all what we have to do is accept this. I mean, the best treatment has to be given for these patients, and I think this molecule has not much of toxicity. Definitely, I think we have to go with this molecule if there is no constraints for the patient. Yeah, thank you.
Thank you very much, ma'am. Nitya, ma'am.
Can you, am I audible?
Yes, ma'am. You are very much audible, ma'am.
So do I have there is another question, ma'am.
Yes, ma'am.
Although Aranaut demonstrated benefit across both high and low volume disease, would you still consider triplet therapy as the preferred option for fit high volume patients, or do you think Aranaut is sufficient to support doublet therapy in selected high volume patients? So basically, Aranaut trial is designed for patients who either cannot receive docetaxel. So I would still, if it's a high volume disease and the patient is fit and he can receive docetaxel, I would prefer Arasens rather than Aranaut.
Thank you. Thank you very much, ma'am. Thank you very much. I think there is no more further question in the chat box. Shall we conclude the session, ma'am?
Yes, sir. Yes.
Yes, ma'am. Thank you very much, Dr. Akila ma'am and Dr. Nitya Priya ma'am, for your excellent presentation and valuable insights on the Arasens and Aranaut studies. We also thank all the participants for their active presence and engagement. We hope today's discussion will be valuable in our clinical practice. Have a wonderful evening. Thank you very much. Thank you very much, ma'am.
Thank you, ma'am. I thank Bayer for giving me this opportunity.
It's my pleasure, ma'am. Thank you. Technical team.
Okay, sir, we are closing the session now.